see that?
Yes,
This
you can see
one?
that.
It's for
Here also, there also.
even on the side.
Working here also.
But you have moved here.
Yes.
See this here.
Can you just...
Just.
This paper should not come. You would like to read out as MD endocrinologist, MDF, or that's not required?
Just endocrinologist and diabetologist.
Endocrinologist and diabetologist from Mumbai.
That was three things.
Right. And when I'm reading, you can see I'm looking down. Can you project a screen carbon? There's no screen. Logged in. Tell me when you're starting. A very good afternoon to one and all. We are privileged to have with us Dr. H.P. Chandalia, the well-known and renowned diabetologist and endocrinologist from Mumbai. Dr. Chandalia is the Director, Diabetes Endocrine Nutrition Management Research Center, that is Denmark. He is a Director, Endocrinology, Diabetes, Metabolism at Jaslock Hospital and Research Center, Mumbai, and he is also the Honorary Professor of Medicine and Diabetes, retired Grand Medical College, Mumbai. And the topic for today would be diabetes metabolic syndrome, targets and therapy. We welcome Dr. H.P. Chandalia.
Thank you very much. Thank you very much for your kind introduction. Good afternoon, my dear colleagues. I'm going to discuss for you today the glycemic targets in diabetes. All of you in diabetes practice are always thinking of this question as to what kind of targets you should achieve. And you know, in any particular disease, target setting is very important for patients to know, and therefore it becomes extremely important for us to discuss that. This is just to declare my conflict of interest. Now, my talk will be divided into these subtopics. First of all, we'll be looking at hemoglobin A1C as a gold standard for judging the glycemic control. Thereafter, of course, a very important concept I will develop for you, and that is the moving goalposts. That is very important thing to realize, that the targets are moving targets and not fixed for every patient. That is, individualization is required. And then, of course, very quickly we'll see how far in our country, or at least in our center, we are able to achieve the glycemic targets that we are discussing. A little bit we'll look at the trend of glycemic targets over the past 1 decade, and it's very heartening to see that our achievement of glycemic target goals is getting better and better in the recent past. And of course, the last part is a very vast subject as to how you achieve these glycemic targets. That almost means total diabetology or therapeutics. But I will allude to a few important approaches which you can take in order to improve the targets that you achieve. You all know that hemoglobin A1C corresponds very closely with mean blood glucose. And of course, you know, there are a lot of formulae which convert the A1C value that you achieve into mean blood glucose, and most of the laboratories report mean blood glucose to patients, which gives them a figure to go by. But I must tell you that when we talk to our patients these days, as a matter of fact, more than mean blood glucose that they should achieve, they all are quite familiar now with that magic figure of 7% A1C. So I think this has gone very well as far as the public education is concerned, that they know that the A1C goal is less than 7%. And this is how the laboratories, when they get their A1C value, they report the mean value, and either in milligram or in millimole. In our country, of course, milligram per DL. Although we feel that hemoglobin A1C is a very faithful average of mean blood glucose over the past 2 to 3 months, yet it is very important to know that very wide excursions in blood glucose, as is shown here, for example, very high levels, high peaks and low troughs together can cancel out each other, and then you can get an A1C which is pretty good, like A1C of 6.8 here, which is the one which you get in another person with very little excursion of blood glucose, and of course A1C of 6.8. So although mean blood glucose corresponds very, very accurately to A1C, the fluctuations in blood glucose are not reflected in the A1C value, and for that purpose you will require either multiple sampling by set blood glucose monitoring or doing a CGMS or continuous glucose monitoring. Now let us look at this very important concept of moving goalposts as far as our glycemic control is concerned. Now, some time ago, almost about 10-15 years ago, I did an editorial in one of the journals where this concept was being developed at that time. That is that every diabetic that you see cannot be brought to the same target level, and really the target should be changing depending upon what kind of patient you are dealing with. And in this particular table, we looked at our patients, and of course we showed that those who are of less than 10 years duration of diabetes, the goals could be stricter, while those who have diabetes of long standing, the goals will have to be somewhat relaxed. So this concept was developing with the clinicians for almost last 2 decades, but it has really found a wide publication only occurred in the last 2 or 3 years, and some of the associations like ADA or EASD has really incorporated this only in their last guidelines, like guidelines by ADA at the end of 2013, or they are called 2014 guidelines, where they have now mentioned that although an A1C of 7% is the best correct one in most cases, but there has to be a change and individualization, and they are talking about better control and A1C of 6.5 in patients of short duration of diabetes who have long lifespan ahead of them and who do not have vascular complications. Their A1C can be even better. So this concept develops with clinicians for a long time, but finds its place in the recommendations much later on, and that happens everywhere in medicine. Now, how do we really decide what is the correct target for that matter, any particular parameter? Now, one way, of course, is looking at a large number of people and, of course, getting your mean and standard deviation, and we know that mean plus minus 2 standard deviation takes care of 97% of people. That is statistical calculation of a normal value. However, what is most relevant to we as clinicians really is looking at an optimal target from the point of view of outcomes. So a good target is one where the outcomes will be most favorable and complications will be minimized or almost eliminated, and that is the most practical approach for the treating doctors. So now, what is the complication that we can look at from this angle? You know that in diabetes, vascular complications are very, very common. Microvascular, macrovascular. Now the macrovascular, besides being dependent on the status of glycemic control, also depend upon the status of other comorbid conditions, especially the lipids and blood pressure and tobacco abuse. So Therefore, you cannot look at as it, or you cannot derive your calculations of glycemic target based upon macrovascular complications. But diabetic retinopathy, which is a microvascular complication, is truly dependent upon the status of glycemic control. As a matter of fact, this particular complication really dependent upon the severity of hyperglycemia multiplied by the duration of diabetes. And therefore, for example, here you see very famous H-Hinz data from US, where you see a sudden rise of retinopathy somewhere when the A1C is very close to about 7. 7, you see a brisk rise. There's a very fast, very vertical rise of the curve. The slight rise before that you see here, which starts from 6.5 A1C to about 7. So if you look at this type of data, you are convinced that probably an A1C of 7 is a reasonable target in most diabetics that we think about. Now, besides looking at the A1C, one would always consider in glycemic targets what kind of blood glucose you should achieve. And different associations have really given their criteria for A1C as well as for blood glucose. It is really surprising that until 10 years ago, some of these guidelines, including ADA and EASA guidelines, had not differentiated the glycemic targets in type 1 and type 2 diabetes. Although most treating diabetologists understood this extremely well, that the type 1 diabetics cannot be as well controlled or as easily controlled as type 2 diabetics, and therefore the glycemic targets in these two groups have to be different. Some of us, of course, have realized this long ago, and many of us probably gave lectures where this was separated almost 2 or 3 decades ago. So this is a very important concept. Now the blood glucose that is recommended, the target that is recommended pre-meal, is something like 70 to 130. If you see the ADA guidelines issued just at the end of 2013, the fasting or pre-meal blood glucose is 70 to 130, and post-meal they say is less than 180. Now you will appreciate that here also, as we are looking at individualization of the A1C targets, similar individualization is required in case of glycemic control as well, but not many of the recommending bodies have yet paid much attention to that the blood glucose is to be achieved also will be different in different type of diabetics, and the criteria therefore has to be different. So this is giving you goals between type 1 and type 2. In type 2 it is a bit easier to achieve good glycemic control without producing bad hypoglycemia, and therefore the targets one wants to achieve are a bit tighter and bit lower. So for example, this particular slide again shows something like that. The type 1 diabetic, for example, pre-meal 70 to 140 instead of 130 that is said. For example, the ADA again gives type 1 and type 2 similar glycemic targets in their last report. However, it will be different in 2 categories, and of course postprandial less than 180 in type 1. However, in type 2, postprandial you can easily achieve less than 150 in majority of type 2, especially in type 2 who are of recent onset. So therefore again some degree of individualization should occur in this area as it has occurred in case of A1C. Again showing you the effect of duration of diabetes, which I showed you earlier. Again, this is our recent data showing again the diabetics of long standing, like less than 10 years and more than 10 years, the A1C target can easily be about 0.5% different. So long standing diabetes, you probably are happy with a target instead of 7, maybe 7.5. And of course, as we will see, some other different considerations in deciding what kind of targets you should set. You will appreciate that in some of them, even today, A1C of 8 also may be acceptable. Now we look at one very important aspect which really also changes our glycemic targets. and that is the complications. You are familiar with the trio study, that is Accord, Advance and VADT. And I'll take up the Accord study a little bit here to show you that in this study where diabetics of somewhat long standing, most of them more than 10 years, and having cardiovascular complications were enrolled for the study, and very strict targets were attempted, like a target of A1C of less than 6.5, there was really increased cardiovascular mortality. And of course the other two studies, Advance as well as VADT study, also gave a similar idea that in people with long-standing type 2 diabetes, with cardiovascular complications, it may not be desirable to set very strict targets or very strict goals. One, they may be difficult to achieve, and secondly, it will produce a lot of distressing hypoglycemia while you are trying to achieve that, and last of all, it might do harm to these people and the cardiovascular mortality will increase. So from this we learn that without existing cardiovascular disease, intensive control is beneficial. With existing cardiovascular disease, intensive control may be detrimental. There are some analysis of these three studies also showing the speed with which you achieve the targets also is an important consideration. In case you lower the blood glucose very rapidly, then there is a chance of producing problems in those who already have cardiovascular disease. So this is also another important consideration. It is very heartening for us to know that patients who can achieve very good targets are the ones who are recently discovered somewhat young type 2 diabetics without complications. And frankly, this is also the group where the present modes of treatment that are at our command can achieve realistically a good control. So our targets as well as the tools we have to achieve those targets fortunately are in consonance. They are not at variance. So therefore, so recently discovered diabetic, try to control, possible to control very well, and you should do it. Again, also the concept of glucose memory is very important. That first 10 years of diabetes, what control you achieve, what benefits you derive is far outweighs the advantages that you will derive by doing a good control in the later 10 years. So the glucose memory effect is a very important concept also. Fortunately, all of this falls in one place because they are the same people where you want to achieve and where you can achieve good diabetes control, and the other group where you should be somewhat relaxed. So this is very important concept. Now the recommended glycemic goals in initial therapy. What kind of A1C should you achieve once a diabetes diagnosed, like type 2 diabetes is diagnosed, and what kind of A1C you should achieve? Now, for example, some recommending body like AAC, Association of Clinical Endocrinologists, recommends somewhat stricter control like A1C of 6.5, while ADA is talking about 7. Initial therapy, although what is stated in this particular slide or what has been brought out by the association is somewhat flawed for the simple reason that although the A1C can be very high initially, the response can be spectacular in type 2 diabetes. For example, this particular slide tells you that if the A1C is high, you should really use dual mode of therapy or sometimes even 2 drugs right to start with. This may not be correct because whatever is the state of initial glycemic control, the response can be quite spectacular in most of these people, and many of them are controlled even now with monotherapy. So this is again a very important concept. The initial therapy usually should be simple. You may note here that sulfonylureas are hardly used nowadays in initial therapy because of the reasons that we will talk about a little later. And of course the triple therapy comes much later on. Now another very important concept which also makes you change your glycemic targets, and that is the mode of treatment. For example, like somebody is controlled very well on exhibiting simple oral agents, 1 or 2 oral agents, then the A1C that you want to achieve can be much lower than a patient who is on triple drug therapy and is poorly controlled. There the A1C target again, and of course when you give insulin therapy, often the A1C targets can be somewhat relaxed. It's not because insulin therapy is inefficient in controlling diabetes, but it is for the region that you see at that particular state of diabetes. It's a long-standing type 2 diabetes where oral drugs have failed, including triple combination, and then you exhibited insulin therapy, and therefore you will find difficult to control these people, and therefore the A1C targets are high. For example, if you take insulin pump therapy in type 1 diabetes, now type 1 diabetes, even with intensive insulin therapy with 3 or 4 injections of insulin per day, I would think that a target of your 7.5 A1C is very good to achieve. However, if you really want to achieve less than 7 or 6.5, it will have to be insulin pump. So depending upon what mode of treatment you are employing, whether it is simple oral agent in the beginning of type 2 diabetes, or a complex therapy after 10-20 years of diabetes, or insulin therapy, or insulin pump, your targets will be different. So this is another factor which determines what kind of targets you should set for your patients. Pregnancy is one situation where the target setting is very, very important, and very important for the outcomes. But how do you decide what kind of targets you should achieve in pregnancy? Now, like I told you, that any target setting can depend either on normative data or outcome related data. Normative data is you see the A1C in non-diabetic pregnancies, large number, and you calculate your mean and standard deviation. And of course, outcome related, which is extremely important, as I told you, for clinicians to consider, has been very, very seriously applied in case of pregnancy with diabetes. And you know very well that outcomes, the adverse outcomes that occur in uncontrolled pregnant diabetic is of course large babies or macrosomia, and of course neonatal the mortality can increase, and therefore, and of course early on in the first trimester, fetal malformation occur. So looking at these 3 outcomes, there has been calculation as to what kind of targets you should achieve. And of course, based on normative data, fasting blood glucose less than 90, postprandial less than 120, and A1C less than 5.3. This is what happens in non-diabetic pregnancy, so you like to achieve that. And again, trimester related normative data is there, slight difference between first, second and third trimester, but average again about 5.3 is very good target to achieve in general in pregnant diabetic. But the outcome data, if you see again here, if you see fetal anomalies, depending upon how many standard deviation above the average you are in A1C, the fetal malformation can occur to a great extent, as you see, as you go up on A1C. And of course, here again you have the data related to outcome, and if you see the adverse serious outcome, the last column, you will realize that A1C of 7 is a very good idea, and it will give you the perinatal mortality and all serious adverse outcome which are almost comparable to a non-diabetic pregnancy. So once you achieve that, so this is how the target setting occurs, because now you are coming close to the complications which occur in the population at large, and therefore that obviously is a very realistic as well as a scientific target. So A1C pregnancy again we consider, so we'll move rapidly. Now, if I wish to summarize all that I talked to you earlier, I can say that targets are different in type 1 diabetics, type 2 diabetics, and of course pregnancy. And when you take different types of type 1 and type 2 diabetics, like type 1 diabetic on insulin pump, I would again try to go for very strict targets, but otherwise probably I'll be happy with an A1C of 7.5 or even A1C of 8 in the long-standing type 1 who has already complications. Type 2 diabetic recently discovered, it may be possible for you to achieve a target of 6 or 5.5 even, but as you go with long-standing type 2 diabetic, your targets have to be relaxed, and with complications, you may be happy to even achieve a target of 8%, which probably is the outer limit in most of these cases. And in pregnancy, where the target setting has been always uniform in the whole literature, I would like to bring out some differences. For example, if you have treated reasonable number of pregnant diabetics, for example, gestational diabetic is different from pre-gestational type 2 diabetic, and that is different from type 1 diabetic. And I think time has come for us to start thinking, and this is of course a thinking which is being brought out by some of us for the first time, but all of you have to start thinking this way, whether the target should be different in pregnant diabetics with pregnancy of either gestational type, pre-gestational type 2 or type 1. Type 1, for example, 7 will be very good. In fact, you'll have to probably use insulin pump to do that, while gestational diabetic you'll get 5.5 very easily, sometimes just with diet and exercise, sometimes with a single one shot of insulin a day, while pre-gestational require treatment which is somewhat more intensive and falls in between probably what you use for type 1 and what you use for the type 2. Now this was a very interesting paper just about 2 years ago, very interesting one. The concept that I brought out to you, and some of us have proposed, have been published about 10-15 years ago, was beautifully articulated in this article for the first time. And it shows again the same factors, that what type of diabetes you are dealing with. So if you have a recently discovered diabetes with a young person with a very long lifespan ahead of that person, has got good resources, good understanding of diabetes, the restricted control you will try to achieve, like you see all these people on this side of the picture. And if you have, on the other hand, a long-standing diabetes, with vascular complications, poor support systems, and you see then, of course, you are going to relax the control. So this concept of moving goalposts has been now brought out very, very strongly in the literature, and I have described why this concept has come. And the factors which really determine the kind of goals you should set is, as I told you, type of diabetes, life expectancy. So this slide summarizes what are the factors which determine, by which you determine your glycemic targets. So type of diabetes, life expectancy, duration of diabetes, presence of complications, mode of treatment, as I told you, insulin therapy, those people usually will be somewhat poorer control, pregnancy, and then to what extent patient wants to adhere to your treatment, what resources are available, and what kind of support systems are in place which can take care of the lifestyle of the patient, as well as sometimes with the hypoglycemia, the support systems have to be good when you are trying to achieve very strict control. How far are we achieving these targets is a very interesting thing to see. The global status of glycemic control was pretty bad about a decade ago. Most of the countries, the averages was A1C was 8.5 in the clinic population, and below the 7 were only about 20% of the people. It has fortunately improved over the past 1 decade. And for example, of course, we'll show you our data. Initially, for example, what kind of A1C average our patients had, and on follow-up, of course, the whole group lowered by 0.5 A1C, the whole clinic population. And you will see here that A1C of less than about 7.5, I have not taken 7 because I'm dealing with, it's a tertiary clinic, care clinic, and it have all complicated patients with long-standing and difficult type 2 diabetes. So I have put the 7 and up to 8 together. And of course, you'll see that the people under control when they came to us were about 40%, and with control they came to 50%. All over the world, the good glycemic control as far as A1C is concerned has been shown to be close to 50% in most clinics. Depending upon what kind of population you're dealing with, can be better. Like if you're treating mostly young diabetics, type 2, and recently discovered, then of course your control, A1C control can be in almost more than 50, maybe 60% of the people. But we are still not anywhere close to 70, 80% below target, because that seems a very distant goal, considering the fact that the modes of treatment available at our disposal have to improve in order to do that, and the education both of the patients as well as the healthcare provider has to improve considerably. Duration of diabetes we already looked at determines, and people on different mode of treatment like OHA, insulin, the A1C achieved can be different targets. So these are some important things. Now the trends we already see, and of course this is interesting, comparing the trend in two different periods, up to 2002 and then further down up to 2009. You can see that A1C targets which were achieved, sorry, can I go back? A1C targets which here you see were achieved. For example, you see in about 43% of people it really improved to 54. So 10% more improved. So this is something heartening. Why it has happened? Those are something you see very interesting, would be very interesting to see. Definitely the education has improved and some of the tools we have available to deal with diabetes improved. We have better insulins and we have better oral agents, especially DPP-4 inhibitors and GLP-1 related therapy have made the difference. This also shows some of the other goals. The A is of course A1C, but blood pressure and cholesterol control. Really to have all these three under control and below the target value is a very difficult task, and you will see not a large percent of population in any center yet achieve that. And I think the challenge for we as diabetologists really is to see how many of our patients we can bring under this A1C control. Of course, now the methods to improve control, I'll go over it very rapidly for want of time, because this is really whole gamut of diabetology is involved in this, but I'll tell you some of the important concepts which can improve the control in your clinics. See, and I'll go over rapidly over some of the very important slides. Okay, this is a very important concept, that when the patient's A1C is very high, like 9 or 10%, it is global hyperglycemia. When you start controlling them, when you come somewhere near 8, it really is more of prandial hyperglycemia. The fasting blood glucose is pretty good at this point of time. So the present day challenge in diabetes centers is there is large number of population stuck at A1C of 8. What can you do to move them to the target of 7? That is a real challenge. And how that can be done, I'll show you very rapidly by some of these approaches that we take, but you all can develop your own approaches. For example, we are now thinking of using early combination. For example, instead of only using metformin, we're seriously considering using metformin and DPP-4 inhibitor right in the beginning of therapy. So this is one very important concept which might be of help in achieving better targets. And of course, you know the weight gain, etc. is a big problem. I think I'll go rapidly. I just gave you some very important concepts there. Hypoglycemia has to be avoided at all costs, but I'll tell you, this is a very important concept. In order to get good glycemic control, especially in the initial 10 years of type 2 diabetes, you should really go more for the what we call anti-hyperglycemic agents like what we describe here, instead of oral hypoglycemic agents. The reason is that anti-hyperglycemic agents, their full dose can be exhibited without any fear of producing bad hypoglycemia. And therefore you can go closer to target without being afraid of hypoglycemia, and therefore this is a very important concept. For example, even when we use insulin therapy 3 or 4 doses a day, for sensitization we always use some oral agent in type 2 diabetes, and there is, besides metformin, some anti-hyperglycemic agent like a starch blocker or a glucose blocker like voglibose or acarbose can be used, or a DPP-4 inhibitor can be used where the insulin doses remain low and therefore distressing hypoglycemia does not occur. So this concept is a very important concept you can apply when you treat the patients. Weight gain has been always thought of as one of the major roadblock for you to really achieve very good control with insulin and sulfonylurea. This was a very interesting paper we published about 4 or 5 years ago in an American journal showing that the weight gain primarily, of course, is more in insulin and sulfonylurea groups, but it looked different, looked from a different angle. Truly the weight gain occurred in those people who had experienced weight loss before effective therapy was instituted. So this is also a very important concept, that weight gain truly will not be dependent upon the mode of therapy you employ, but it really is a recovery from the weight loss by the patient. This, of course, usual algorithms given. I'll not go into details of that. And of course, I tell you, the non-adherence is a problem, and I think the combination of therapy is a very important thing, and the Indian pharma industry really a tribute to them, that they were probably very early compared to many other countries in combining drugs very, very successfully, and of course that really encourages, of course, the compliance or adherence to treatment. So it's a very important thing. The fixed dose combination is not a bad idea, especially when you work out your treatment and then in the end you shift to a fixed dose combination. So this is the adherence part, and this also will help. So I want to summarize our approach to glycemic targets by saying that first of all they need to be individualized. At the present time, most clinics in India are achieving A1C targets in about 40 to 60% of their patients, average about 50%. This is true of our center, and I have checked data with my colleagues in Bangalore, colleagues in Chennai. They all have similar results. Over the past decades, things have improved, and of course we are achieving targets in more and more number of people. Maybe we have brought another additional 10% under the A1C goal. The methods to improve glycemic control, we have discussed very briefly. Use the oral anti-hyperglycemic agents in preference to hypoglycemic agents. Use fixed dose combinations, use the drug early on, and of course use sensitizing agent even when you use intensified insulin therapy. Please remember that in type 2 diabetics, a sensitizing agent, an oral agent is always required, which of course is not very well emphasized in the Western literature. But some of us who deal with large number of type 2 diabetics appreciate it extremely well, and this is how most Indian diabetologists practice. So thank you very much for your patient hearing. So we have some very interesting questions here from your group, and I'll answer some of those because that will clarify. Some of these concepts I've already taken up in my talk, so I'll just briefly allude to that. Now this question is from Dr. Naveen Chatwal from Delhi. No, I'm sorry, this is from Dr. Sujit Patel from Gujarat, from Bilimora. And the question is, does improving glycemic control improve clinical outcomes for inpatients with hyperglycemia? So Dr. Patel is asking us about the glycemic targets in hospitalized patients. And for that, of course, I must briefly tell you that there was a period until about 5 years ago when we all tried to achieve an average blood glucose of about 150 in all our hospitalized patients, either in the intensive care or patients in the perioperative period. That sometimes led to a lot of hypoglycemia as well. And of course there was a lot of scientific literature showing that the outcomes improve, outcomes are good when you do that. However, a study published in New England Journal of Medicine, which all of you might have seen, called Nice Sugar Study, showed that in hospitalized patients, probably keeping the blood glucose below 180 at most of the time gives you as good outcomes, and probably tightening control will produce serious problems or even more mortality. So I would say that in most of these situations, probably keeping blood glucose below 180 is a good idea. The outcomes do improve, but over enthusiastic treatment then can cause problems, as the night sugar study showed. However, again you should individualize, because there are patients where you can get the average glucose of 150, you should try to do that. If it is possible for you to do that with insulin infusion therapy and the basal bolus therapy done properly and monitored very accurately in hospitalized patients, the outcome will improve. This has been shown initially, of course, by a very famous Vandenberg study in people with myocardial infarction, that good control improves the outcome almost by 30 to 40%. So I think this is a very important thing, to control our hospitalized diabetics as well as we can. Then there are some questions which are not directly related to my today's talk, but I'll take up some which are really connected with our topic today. And of course, this one, of course, is very much related to what I talked. It is from Dr. Rajesh Kumar from Delhi. What glycemic targets can be recommended in different patient population. I discussed that we discussed in the moving goalpost that I told you is a very important concept. What are the areas of future research? Dr. Ravindran from Tamil Nadu, Chennai, is asking, what kind of research is possible in this glycemic target? Yes, of course. We still need massive, lot more data to say what the target should be with a given complication. We say in general with complication, target should be relaxed. But for example, with nephropathy, let's say a person with creatinine of 2 or 2.5 milligram, which we diabetologists sometimes treat for 5 years, 10 years before they really make the transit to nephrologist. So at that stage, what kind of A1C is correct one? We say it should be relaxed, but how much it should be relaxed? So this really needs to be settled much better. And of course, the relationship to outcome again has to be far more firmly established than what we have done so far. So there is still a lot of research required before we really set the targets very, very firmly. Now we know that the targets have to be different, but how much different in a given different population and with different conditions, that is not, we don't yet have very, very massive or used data or a good A or B level evidence to really say that with confidence. So I think research is required. Research is always required for that matter in anything in medicine, because this is how we move ahead. So I would say in general, yes, we keep looking at these problems again and again. In patients, again a question from Dr. Rahul Sathija from Rajasthan Kota. We have discussed that. So I think we move on. You see, there's something connected with drugs and all, which I think is not today's topic, but I'll be happy to take some of those questions some other time when we are discussing really these drugs, like some are on sulfonylurea, some are on pioglitazone, but it probably doesn't relate to glycemic targets. I must tell you that some of these drugs, the targets achievement is superb, but there are many other considerations why we use or why we don't use them in a given situation. This is an interesting question from Dr. J.K. Khurana from Haryana, Faridabad. What are the optimal strategies for transition to outpatient care? Now, this is in continuum of the question from Gujarat we had as to hospitalized patient, what kind of control you achieve. So we discussed that. Now when the patient is going home to outpatient care, now what kind of target you give at that point of time? Frankly, at that point of time, the targets can become stricter, because the patient is eating well and eating predictably, and at this stage patient is also physically active, so some amount of activity will start, which will again help you in controlling diabetes. So at that stage you can truly go to better targets, which you know we discussed in the whole talk. So you can really go to the targets that we discussed in the talk at that period of time, while in hospitalized patient, as you said, we will be somewhat relaxed, because hypoglycemia in critically ill people can be quite disastrous. And therefore, you're probably keeping it about 180 milligram is a good idea. This is a very interesting question again by Dr. Arun Agarwal from Agra, Uttar Pradesh. What does Steno-2 tell us about glycemic targets? And this, I think, is a very, very important question, and it leads us to some very important concept in diabetology, management of diabetes in general. Steno-2 was the study where the multiple risk factors or multiple comorbidities were addressed very, very well, very optimally. For example, besides achieving glycemic targets, in this study, the hypertension was beautifully controlled, the tobacco abuse was tackled, and of course the lipids were controlled. And this study, of course, the achieving strict targets really give huge benefit to these people. So what it tells you is that having a comprehensive approach where you address the issues of all comorbidity really improves the outcome, and therefore I want you to note down this very important concept, that although I have talked about glycemic targets today, do think of the other targets, especially the lipid targets, blood pressure targets, and tobacco cessation target. These three you must definitely look at in all your patients and try to achieve those, because the benefit that your patient derives by this multitasking or controlling all these factors is huge compared to only focusing on glycemic targets. So this is very important concept, and I think we should appreciate that this question was raised. This is another very interesting question by Dr. K.B. Tiwari from New Delhi. This is taking our some concepts further. When you are changing your target based upon different things, in your clinic population, how do you differentiate these people? As we discussed, frankly, you look at duration of diabetes is very important. Initial phases of diabetes, frankly, type 2 diabetes, you should really set very strict targets. One, because it is possible to do, and secondly, because it really confers maximum benefit to the patient in the end. The early control gives you maximum benefit. Then look at patients' weight. How do the target differ? Weight. Lean patients, type 2, are very different from obese type 2. Obese type 2, probably sensitization is more important, because insulin resistance is a lot more in the obese type 2 than lean people. Although it is not always true, you can have lean type 2 also is quite insulin resistant. However, lean and obese, your approach is different. You see, so their presence of comorbidity is very important, presence of complications is very important. So again, it comes down to similar things we have thought about, but I think looking at your clinic population, now you should start analyzing that why should you have different targets, and frankly, you should carefully set the target and give it to the patient that in your case, I want A1C to be 7.5. In your case, I want it to be 6.5. I think after probably listening to my talk, you should be able to now differentiate this and really start achieving that. The choice of insulin in type 1, this again connected with therapy, posted for surgery. It's not exactly today's topic, but definitely it has to be intensive therapy, multiple dose, which would be probably basal bolus therapy, 3 doses of human regular insulin or a rapid acting analog, and of course a basal insulin like Glargine or for that matter Digludac if you wish to use that. So I think the therapy has to be that, and of course immediate operative period etc. in the patient, it really has to be insulin infusion by a syringe pump, and of course as they start eating, syringe pump plus bolus injected subcutaneously. This is how the diabetes is managed very well. If some of you want to see these approaches, see in our RSSDI textbook of diabetes, which I edited and which is just out 2 weeks ago. There are 2 chapters there in hospitalized patient and perioperative control, written by different authors, and they really bring out some of the aspects which are not there anywhere in the literature, because these are the authors who are dealing with large number of people than any other author in the Western textbooks. Okay, this is a very interesting question raised by Dr. Shikhetra Nanda from Cuttack, and that is okay. He's saying, and probably, this is the second one. I'm trying to take Dr. Varda Raju from Andhra Pradesh, Tirupati. This is a very interesting one. What he's saying is that what kind of target will you choose for a man who works as an interstate trucker and was recently diagnosed with type 2 diabetes? If he has an A1C of 8.6, this is very interesting, and a body mass index of 32. Okay, this is typical trucker. Not only Andhra Pradesh, everywhere in India, this is trucker. He eats irregularly. We are not sure whether he'll eat a meal or not. We don't know, because it depends upon where he has meal available. I hope he does not drink while driving, but that's a different story. That's dangerous, of course. Now, what kind of goal should we give to this trucker? And recently diagnosed, and he's overweight. Now, I would give this person, although he is a trucker, eating irregularly, I would give him an A1C goal of 6.5. I'll tell you why. One, because he is recently diagnosed. Secondly, although he is unpredictably, I'm not going to use a hypoglycemic drug for this man at all. Like I told you, initial phases we use only anti-hyperglycemic drugs like metformin, glitazone, acarbose, voglibose, or DPP-4 inhibitor. So I'll use probably metformin alone for this man. So no chance he'll get hypoglycemia and have an accident. But I'll give him strict goal like 6.5 because he's recently diagnosed and overweight. I think metformin worked beautifully for this person. So this is a very good example where in spite of adverse situation, you'll give a strict target. Because otherwise you think that this trucker you should not control very well, because he produces problem, but no. If you know how to do the job and what drugs to use, you will come out very well without really using any without causing any serious hypoglycemia. Yes, this question is an important one. We alluded to it by Dr. Manoj Sen. Here, Dr. Manoj Sen. Okay. Yeah, the importance of glycemic excursions he is asking. Dr. Manoj Sen from West Bengal, Berhampur. Okay. Most important measure of A1C is there, but what is the effect of glycemic excursion? I mentioned to you that glycemic excursions are not reflected in A1C, and therefore the self-monitoring of glucose has to be there, complementary to A1C estimation. And I think all of us have been underusing CGMS in our difficult patients. I think it's underused in our country. It's underused by me and all of us for the simple reason that it's a little bit more expensive than what it should be. It is expensive at this stage, but I think we should use that in order to detect glycemic excursions, because we do know that even if with good A1C, very wide and very wild glycemic excursions will produce vascular complications and endothelial damage. So I think this is very important, that A1C alone should not be relied upon. And this was brought out in my talk, but I'm glad that I can emphasize it while answering to this question. Okay, now we carry on. Any other questions which you have received now from, or you have any other questions? Yeah, which are received. Oh yes. So we can take some coming live from others at present time. Yeah, this is connected with therapy. Well, I'll take some of those because they are a lot connected with therapy, which is not exactly connected with today's topic, but maybe some of you probably want to resolve some issues while I'm available, so it's quite all right. You see, okay. Now, is there any new recommendation in AACE 2014? Frankly, they have now realized the importance of moving goalposts, and they have given one paragraph that it can change. It should change different people. So that they have earlier mentioned of only 7, they have added 6.5 there, and they have of course added the blood glucose criteria. Blood glucose criteria at the moment are same. Again, they say it should be individualized, but they are given the same for type 1 and type 2, which I think still needs to be improved. So definitely, if you see the clinicians doing it, because as I always said, people who sit in the ADA or ESD committee or any committee are different from, are usually those senior ones who have not been seeing any patients for the last 10 years. So the recommendations come out a little better if you really have some professors who are treating patients and then they sit on the committees. Okay, so yeah, this question is related to therapy with the combination of sulfonylurea and glimepiride sulfonylurea, glimepiride and metformin 1000 help achieve glycemic targets better than triple combination. Triple combination, I'm sure we probably mean combining with glitazone, that is maybe bioglitazone. That is probably the classic triple combination. In India, of course, the third or fourth drug used also is voglibose or acarbose, which the other countries have used sparingly, but we find these are very extremely useful. And even today when I asked that question about these drugs to an American, he totally nonplussed because he hardly used it. See? So anyway, but I must say that pioglitazone use is a big story. So I cannot take up that controversy in the short time we have today. Now, a very effective drug, very effective drug. We have had difficulty with that, all of which you are very aware of that there is a question raised about the use of pioglitazone increasing urinary bladder cancer. However, used in certain doses over certain years, it is still probably, in some given patients, it will produce superb metabolic control compared to any other drug. The efficacy is absolutely spectacular, I must tell you, compared to many other drugs. So when those of you used it, you probably understand that. Edema is a problem and weight gain is a problem. If you have a lot of weight gain, obviously, you would probably omit the drug. But probably used in small doses like 7.5 for a period of 3 years or so, probably is still on the card, because otherwise your combination will be metformin and probably DPP-4 inhibitor. Presently in my patients, frankly, the combination is first, of course, metformin, sometimes metformin with DPP-4 inhibitor right away. Then, when the two drugs being used, it is metformin and DPP-4 inhibitor. Sulfonylurea comes as the third drug. And pioglitazone comes once in a while when I cannot switch to insulin therapy for whatever reasons, patients' reluctance or whatever else is happening, and then I use pioglitazone. So use is becoming less and less, but I think they are still used cautiously and judiciously for a limited number of period. I think it's okay. But I think using, instead of triple drug, using these two, glimepiride and metformin in large dose, I don't know. Pioglitazone, probably additional 7.5 will be far superior as triple drug than using only metformin and glimepiride. Glimepiride dose will be very large when you do the two drugs, and that can produce bad hypoglycemia at times. So you keep glimepiride dose low and use pioglitazone, which is anti-hyperglycemic drug, you come out very beautifully with good control and not much hypoglycemia. So these are some very, very fine nuances of treatment. We'll take with you some other time when we are really discussing therapy of type 2 diabetes. Okay, this is in terms of A1C reduction. How do you rate? You see, sulfonylurea metformin combination against gliptin and metformin combination. This is a very interesting question, because this commonly used drug, sulfonylurea metformin, is the commonest combination after metformin failure at the present time. Except that slowly some of us have switched to metformin and gliptin, DPP-4 inhibitor, and add sulfonylurea as a third drug. So this is the approach some of us are taking. But our patients are different type. It's the urban group. Many of them are affording to buy the DPP-4 inhibitor, which is expensive. See, so this is a different population I deal with. These are the people, education level is high, compliance is, adherence is better. So this is different. You could still continue to use sulfonylurea after metformin failure, add glimepiride or glycoside as the two commonly used sulfonylurea currently. Glibenzylamide is less used, can produce bad hypoglycemia, so I'm sure most of you are probably avoiding that. Now comparing these two is very difficult, because although gliptin and metformin might give you an impression that lowering will not be as good, because sulfonylurea give you impression of being very potent drug, but let me tell you, both of these combinations, to my mind, will produce almost equal lowering of A1C. Most of the data in the literature show that combining gliptin and metformin can produce as good results. And of course, hypoglycemia will be much less. So I think whatever said and done, gliptins are having a sway now in a big way in the therapy of type 2 diabetes. Either initially in combination therapy, metformin failure in addition of gliptin, adding a 2-drug combination, a 3-drug combination gliptin, and gliptin with insulin therapy. So frankly, gliptin everywhere. But this is what the trend is, and most of us are are following this trend and frankly getting pretty good results. So I think this is probably they are equal. Now here is a question as to what resources are available. This is from Dr. Mahadev Patel from Gujarat, Rajkot. What resources are available to support more widespread implementation of the glycemic guidelines? Oh, okay. I think the education of physician, education of patients, people with diabetes. You see, the biggest resource really is education. Most powerful tool in treating a chronic disease, besides all the drugs we keep talking about, is education. That's the most powerful tool anywhere for solving a big health problem. So I would consider that if we can increase our education, and I guess this is what we are doing today afternoon, and this will improve the widespread implementation of glycemic guidelines, because all of you now know at least where the target is. And once you know the target, then of course you find your way to its target. Like presently in India, we are all galvanized by targets which have been set for our country as a whole. By tomorrow is the cleanliness target. So once the target is set, and we obviously find out ways to do it, and there are already guidelines issued to many people in the government service tomorrow where they should be found cleaning the place. So I think the targets will be achieved when people get educated. There is a question by Dr. Kalyan Mitra from West Bengal, Berhampur. What is the expected time frame of benefits of diabetes intervention, including complications, screening and care? Such studies will likely require the use of longitudinal studies and registries rather than randomized controlled trials. You are absolutely right. Any vascular study has to go at least beyond 5 years. If numbers are very large, then it will probably achieve the level of significance or power in about 5 years' time. And obviously any randomized controlled trial which is short, like 6 months, 1 year, is not going to give you answers. In our country, at the present time, really the hypothesis-driven research is rare. We have had research from south of India, which is very spectacular, but it is limited to epidemiology. It's limited to cross-section of a population. It is limited to certain figures, which was important for us to see, but it's not taking us anywhere in exploring the questions that you raise, or questions like this. So these are hypothesis-driven studies, and longitudinal studies of this type will require a lot of collaboration between different investigators. And let's hope that as Indians we learn to collaborate, because that is one quality which is lacking probably with us. At least I realized at the background of my career that collaboration with colleagues is a more difficult task in this country. Yes. Yeah. Now this is a very interesting question. Amit Saraf from Maharashtra, Mumbai. Does the targeting of near normal glycated hemoglobin reduce the rate of cardiovascular events? This question has some hidden, agenda there. I can tell you that. What he's trying to ask is very important. All right, you normalize A1C, but when we say target of 7, it is not normal. It is not normal. And of course, glycemic variability may be still there. Glycemic excursion may be there. So complications will be there. What he is trying to find out that can you ever, if you totally normalize the blood glucose, will the person be like a non-diabetic as far as cardiovascular events are concerned? Something very likely that it will be so, but we don't have good evidence for that, because so far none of us have produced a very large number of diabetics with normal A1C. Normal is like 4.5. We are not talking of 7. You can only do that in type 2 diabetic, recently discovered, diet and exercise, very strong, 10 to 20 kilo weight loss, and they are normal if they continue to do so for 5-10 years. This group can be compared probably, you see, or this group can be compared with a non-diabetic population to see whether there are some genes co-inherited with diabetogenic genes which lead to vascular problem is a big question. It has existed 50 years ago when I started my diabetology career, and it is still a question now that inheritance of diabetes, you know, is multigenic. And are some of those genes also shared in the cardiovascular pathology is important. In that case, you will never be able to eliminate cardiovascular problems in diabetics, even if theoretically you achieve a perfect control of diabetes. So this question will arise now when our treatment modalities improve. At that time, this question can be raised, and it will have to be answered one day, and probably our genetic studies, which are very complex in diabetes, we have no easy answers there, will show us that some of those genes which cause diabetes probably are also the ones which cause vascular problem as well. So in that case, of course, we'll have to really wait for gene therapy, which, you know, is not likely in this whole century as far as type 2 diabetes is concerned. It will be there in many other areas, but this is extremely complex genetics for us to tackle. Okay, right? Can we close? Thank you very much, all of you, for your questions.
Thank you, Dr. Chandalia, for sharing us your clinical insights and for even answering a lot of queries. We are, in fact, thanking you to be a part of our Aristo Diabetes Forum. Thank you, Doctor.